1, 2, 3, 4.
Well, that's very kind. I'd like that. So I've got a chance to.
Be queuing up in here.
My name is Barry Patel, and I'd like to welcome you to the NPA session on the future of saving the healthcare and the pharmacy, providing the solutions. It's my pleasure to introduce James Cusick, who's going to chair the meeting and introduce the panels. Hopefully, we'll get some answers along the way. James.
Thank you.
Thank you.
We're about a couple of minutes early and we're waiting for one other guest, I think. So I'll do what everybody does in this situation, which is I'll talk for a bit and hope he arrives, and then nobody will notice. Really relieving the pressure, pharmacy's role in saving the NHS. Probably nobody in this room will be in doubt that the NHS and our hospitals and our GPs are under a degree of pressure. They face rising demand and I think rising expectations of what they can and should be doing. But the pressure is fairly substantial. TV programmes, enough stuff in the press have been written of how many GPs are planning to quit, take early retirement, how A&E departments are struggling, not just occasionally, but every day. And the government sometimes looks as if it wants to solve the problems, but can't quite come up with policies that sound or look immediately relevant. Well, over the next hour or so, I think we can probably identify some areas where the help is out there. And that doesn't necessarily mean a massive addition to the 120 billion budget, which is the NHS. It probably means a degree of efficiency, and maybe particularly relevant to a Conservative conference is an organisation, a key part of the health network, which says they can do more and they don't necessarily need a fortune more to do it, and that technology is out there and that it's not going to take that much to do more to alleviate pressure on the system. Now, that magic organisation, if none of you don't know already, is community pharmacy or neighbourhood pharmacy. But there are obstacles in the way to that. Now, there was a letter last year, an exchange of letters between the Prime Minister and the Chancellor, where the Chancellor talked of wanting more innovation, more supply solutions, more digital technology. Now, had security allowed us to bring this through, I was going to ask one of you to stand up and say, anybody here a pharmacist? And you could stand up, and I would say this is what a pharmacist look like. Now, Philip Hammond thinks a pharmacist looks, in the future, perhaps looks like a small model with a couple of wings on it that would fly and deliver medicine to you. Now, that's not quite a pharmacist, but if that's what the letter to the Prime Minister said, then that's what's somewhere down the line. Now, effectively, pharmacy for myself and for those that I've spoken to, pharmacy is, if you like, the safety net, the last gasp, the last part of the structure of medicine. And I think that a drone perhaps is not necessarily the way. So I hope over the next hour or so, this expert panel, who I'll introduce in a minute, will maybe come up with some solutions. Now, rather than us talk to you for an hour or half an hour and the audience remain silent, can I introduce each of them individually and then break into a discussion? So if anybody wants to say anything, can we have a discussion in between each of the panelists, and then we'll see what happens. I'm going to keep this MP for last. Can I start with the gentleman at the far end? Dr. James Noyce is a writer and an academic. He's currently head of policy and strategy at Res Publica. Now, that was founded in 2009 by Philip Blond. He's sometimes been called Res Publica has sometimes been called the intellectual cradle of progressive conservatism. Now, Philip Blond was one of the driving forces behind David Cameron's Big Society. Can I ask many people how many remember the Big Society? And how many of you remember David Cameron? Oh. James was at the Labour conference last week in Brighton, and this is a remarkable feat. He went there actually without a security guard or body armour, and I think that deserves a round of applause in itself. We have Andrew McCracken. He's head of communications at National Voices, which is the coalition of health and social care charities in England. Now, prior to joining National Voices, Andrew was head of PR and communications at London's South Bank University. He's led public affairs teams at the Royal College of Physicians and has held a number of communications posts within the NHS. Now, there's one definition of communication that I particularly like, and that's a two-way process of reaching mutual understanding. Now, apparently no one in Brussels has apparently heard of that definition, but there you go. And Celia Annam, she is president of the Royal College of Nursing. She's a clinical nurse specialising in sexual and reproductive health at the Margaret Pike Centre in London. Now, I'm going to be as delicate as I can. Among the services available at the centre is emergency advice for those who think they may not have taken adequate precautions. Now, I'm told this does not include those who made the serious mistake of telling pollsters they would be voting for Jacob Rees-Mogg. And Ian Strachan. He is chair of the National Pharmacy Association since 2014. He's worked as a forensic scientist at the Home Office labs in Aldermaston and as a teacher. He studied pharmacy at university and has worked as a consultant in a number of consumer health industries. He runs 4 pharmacies here in the Northwest, not very far from this conference. And in this discussion this afternoon, I think he represents somebody that we should focus on if we have fresh questions about frontline pharmacy. He is very much at the front line, and if there's custom and practice that we don't understand, then let's bring in Ian as quickly as possible. We have one guest, and if he turns up, I will introduce him. If he doesn't, then we'll just go on without him. Can I ask Andrew to kick us off, please?
Yeah, very happy to. Hi everyone, thanks for having us here. So, as per the introduction, I work for an organisation called National Voices. We are a coalition of 160 health and care charities, and our job, we believe, is to try and speak up for patients. And the sort of thing that we're interested in is getting joined up care that's centred around the actual needs of people, rather than focusing on the system or the system's needs. And to that extent, I might reframe the question of the entire event, if that's okay. About trying to relieve pressure on patients as well as just the NHS. And I think pharmacy's got a really important role there. We all know from all of the headlines we've seen over the past 2 years about the pressure in the NHS and in social care, and a lot of that being due to rising demand. But there's also a systemic issue of where the NHS focuses its efforts. So it's, as a system, been around for a long time. There have been lots and lots of advancements in medical science, but less advancements in the way that we deliver care. There's still a very strong focus on treating ill health rather than keeping people healthy. So some of you may have heard the phrase National Illness Service, because that's more what it does. And of course, there's a really important role for the NHS in saving people when they're in crisis, but we would argue that more money should be put into primary care and more focus put into primary care, including pharmacists and pharmacies, to avoid people getting to that crisis situation where they need care that's extremely expensive. So onto pharmacy in particular, we strongly believe there's huge untapped potential there. That pharmacy could play a significant role in particularly helping people with long-term conditions. So the core customer of the NHS are people who are going to have conditions for the rest of their life. It's not people who go in, get fixed, get sent home. It's people with asthma or dementia or some types of cancer, or these sort of long-term conditions that you don't get cured from, you have for the rest of your life. In a system where it's difficult to access your GP, being able to go in and just call by your community pharmacist, that is a fantastic asset that we are not realising the potential of currently. They could help people, for instance, with things like medicine reviews. So if you have multiple long-term conditions, you might be on 7, 8, 9 different drugs, and there may never have been a sort of holistic review of how they interact with one another with you and your condition. So there's a real role for pharmacy there, but also in prevention. So I don't know if any of you have seen the National Pharmacy Association stall in the main exhibition hall, but I was there earlier on getting my blood pressure checked. Really interesting stuff. Turns out it's not too high, it's too low, so there's something for me to be aware of there. And if I was able to just drop into the pharmacy and have that done rather than pay for a conference pass here, then that would be fantastic. But there are some barriers to it. So we, with some of our member charities, did a workshop recently looking at the role of pharmacy. And we think there's a perception issue when it comes to community pharmacy. I don't think many of the people we gathered together in the room, some of whom are people with lived experience, patients themselves who are living with long-term conditions, they weren't aware of the skills that pharmacists have and what could be possible within community pharmacy. So there's a perception or perhaps even public relations thing there about explaining what pharmacy can do. But also there's something about bringing integrating pharmacy more with the rest of the system. Some basic things like the pharmacist having access to your medical records, and not just to be able to read them, but to be able to edit them, to be able to update them. So not only is there a perception thing, but from the work we've done with our member charities, there's also something quite important about integrating pharmacy more with the rest of the NHS and social care and housing and anything else that impacts on your healthcare for that matter. So that's a few thoughts to stimulate the conversation.
Thank you. I forgot to introduce myself quickly. My name is James Cusick. Up until recently, I was political correspondent of The Independent, and I've been a lobby journalist for a long time, both at the Sunday Times and Newsnight. This is unusual for me. I usually end up reporting rather than chairing, but this is a different role. And joining us, and I wasn't going to introduce him just in case he turned up, and then it would be a black mark against his name, so I didn't do that. This is Bim Afolami. He is MP for Hitchin and Harpenden, the old seat of Peter Lilly. He's one of the new intake in this year's general election and was recently elected to the Public Accounts Committee. Now, I know that the electors of Hitchin and Harpenden clearly wanted to keep standards up after Peter of many years. Now, Peter was educated at Cambridge and Dulwich, whereas Bim is Oxford and Eton, so who says the Tories don't do radical? He worked as a corporate lawyer in Freshfields. That's one of the big magic circle firms, I understand. Is it? So any magic tricks he wishes to perform this evening will be fine. I'm going to leave him time to get his thoughts together, and I'm going to introduce James Noyes at the end, who has been doing some work for the NPA, some new research, has some new ideas about where he thinks this entire debate should be going, which is not necessarily in the direction that it has been going. And actually, during the Labour conference, there was a couple of noises from James that clearly had people uneasy in their seats, and I hope he will do exactly the same thing for you this afternoon. Thanks, James.
Thank you, James. It's true, I didn't need a bodyguard at the Labour conference because for many Conservatives, we at Res Publica aren't seen as real Tories. We're called Fabians in pinstripes, which I think is unfair. I don't own a pinstripe suit. I suppose the problem for many free marketeers is that we're interested in the relationship between the state and local institutions. And one of my roles this afternoon, I hope, is to make the case that community pharmacies are an example of civil society, enterprise, community, and a small shop mentality which really should be at the heart of conservatism. It's true that we are writing a report at the moment for the National Pharmacy Association, and we're delighted to be here as part of our Conservative Party conference presence. This topic of community pharmacy reflects for us our wider work on localism, communities, public well-being, and what we see as anchor institutions on our high streets. And we feel this is particularly relevant in the context of the Prime Minister's agenda of social reform, what she calls the reform for the just about managings, the jams of this country. Now, these institutions, many of which are unique to this country, are, we feel, being undermined by measures of austerity. And I feel that it's important we look at the questions around community pharmacies in terms of a wider social, economic, and political debate. So I don't feel this is a niche topic that you should be concerning yourself with. This is something which reflects a much wider issue facing the country, that relationship between the state, the market, and anchor institutions of our communities. Now, we feel that the clinical case for community pharmacy has already been well made, and you'll be familiar with the PricewaterhouseCoopers report of 2016. It talks about reducing the strain on GPs, changing the nature and the perception of public health, and how this can achieve savings for the Treasury, which they estimate runs at about £3 billion. We're interested in what the social savings could be, making the social case for community pharmacy, not just a clinical case. So issues of health inequality and its relationship to poverty, to areas of access and education, of wider public well-being and population health. And this can also, like the clinical example, be costed and mapped. And our forthcoming report will look at the main social challenges facing the UK: mental health, employment, being fit for work, addiction, and how that overlaps with the main public health concerns like diabetes, obesity, and blood pressure. So by making that link, we can build on peer-reviewed studies from pharmacy that look at the relationship, for example, between BMI and unemployment, or mental health and social exclusion. And making that link, the clinical benefits of community pharmacy can begin to be seen in terms of wider social benefits too. Now, as part of wider government thinking about social reform and those just about managings that I talked about, we feel that pharmacy should not be seen only in terms of reducing the strain on GPs, but could also be linked to areas of interest around job centres or places of work, social care, and civil society institutions. And we argue that community pharmacies are the vital vehicles for this, and as such, need greater recognition from government, community leaders, and the various commissioning structures of the NHS. Thank you.
That's two speakers where we've both heard of potential efficiencies that can be had without doing too much. Amanda was talking about what they can do in terms of pharmacy looking at hypertension, diabetes, blood pressure management, adaptation of doses, prescribing and adaptation of medicine. The last time any statistic was looked at and this analysis was done, it was roughly the equivalent in time frame of about 5,000 GPs a year without doing too much. And again, James was talking about inequalities. Now, in the recent court case where the Secretary of State's decision to cut back pharmacies was looked at, it was claimed that 40% of pharmacies were in clusters of 3 or 4, were within 10 minutes walk of each other. What became evident in that court case was the inequality of distribution of pharmacies is not necessarily a balance. Pharmacies usually are in places where they are most needed. Largely, we've got GPs spread over the place, mostly in affluent areas. In the less affluent areas where you would expect GPs to be located, that's probably not the case. Now, there's a duty, if you like, on the Secretary of State to reduce inequality, and I hope that's something that you would wish to comment on. So before I go to the next speaker, any immediate questions from anybody? Yes.
Just a bit concerned about data protection.
Sorry, can I, there's 2 roving mics. Can you just wait till the mic comes, then tell us who you are, which would help, and then let's see what happens. Thank you.
Yeah. I'm Thomas Dunn, Denton and Reddish, Conservative Association. I'm just a bit concerned about data protection. If there was regarding pass it on to a private pharmacy, any data regarding NHS, and also the cost involved. How much would it cost to roll out like these type of services into pharmacies?
Okay, James, can I bring
the concern of a data protection. So many pharmacists, community pharmacies at the moment, are seeking greater coordination in terms of health records between their services and GPs. So if you're going to have a truly integrated health system, you need to have some sort of mechanism by which pharmacies and GPs and CCGs and other areas of primary care speak to each other. I recognise that concern over data protection. I also felt that 10 years ago when this began to become an issue. I suppose my response would be this. If you look at what the Chancellor is talking about and you look at where the trends are going, we're seeing a kind of Amazonization of pharmacy. So it's going to become increasingly automated, and you will plug whatever your needs are into a mobile phone. It'll be dispensed by FedEx and you'll get it the next day, which is a really big problem in terms of face-to-face interaction. Why would one be less concerned with the data protection of an automated system? Machines which have everything they need to know about you already and will increasingly have that information as you put more of your health needs into that kind of Amazon model of community pharmacy. For me, that's far more worrying than if it's in the hands of GPs and the NHS. Why? Because it's been a tool for private companies for profit and not the state for public health. That'd be my response.
One other question. Mike is on his way.
Yeah, my name's Nigel Dugmore. I'm a community pharmacist and pharmacy superintendent, and it really, really irritates me about this data protection, because you can get apprentices at doctors' surgeries who are 16 years of age and can access all medical records. There's no problem at all. I've got 30 years experience in pharmacy and I can't actually access medical records, or can only get supplementary records to try and help people that come into the pharmacy. So I think there's a bit of a, it needs to be addressed, because there is this public perception that records in a community pharmacy can be accessed by anybody, and we'll all go down the pub and tell people what's the matter with that particular person. But we are all covered by the same rules of confidentiality as anybody else in the NHS, and it shouldn't be a problem, but for some reason it is.
Andrew?
I just wanted to come in on the benefit to patients of shared data. So not just for the benefit of the professionals and making their life easier. A couple of years ago, we asked some people who are living with long-term conditions to just draw their interaction with the health service, and what we got was this vast web. And there are lots of people out there who it's almost a full-time job keeping on track of what appointments you need to be at when, what doctor you've told what specialist doesn't know the other thing, then what does the pharmacist know or not know, and the GP, where do they fit in? So what we hear time and time again from those people that we work with is that more joined up data would be a really big positive for them. Granted, there are issues of trust in the system that need to be sorted out, but the need is there.
Anybody else? Actually, as soon as anybody mentions IT, there's usually a flood of questions that basically criticise anything to do with IT and any government system. And it's if you break down the NHS into its constituent parts, there's always criticism that they lack the ability to talk to each other. So although we're actually concerned about protection of data, just distribution and access and the using of data probably is usually what comes up quite quickly. Can I bring in Ben straight away? He's, as I said, just arrived.
So, well, first of all, I'm sorry for being late. I couldn't find where we were going. So, I think I principally want to think about or discuss three things. You've really got, and we've already heard from people who know much more about it than I do, but in effect you've got clinical benefits, you have financial benefits, and you have social benefits from community pharmacy. And I'd just like to give you a few thoughts I have, for what they're worth, on those three, and not present so much complete answers, but more just how I think about them from the perspective as a Conservative MP who thinks and cares a lot about this. So my mum's a pharmacist, which is one of the reasons why I think and care a lot about it, whether I like it or not. So in terms of the clinical benefits, I think it's already been pretty well elucidated. It's well known that, first of all, there needs to be an increased focus on prevention at primary care level, rather than effectively waiting for people to get really ill and dealing with them in a very expensive and difficult way in hospital, which is better for everybody, whether it be staff, patients, society, the like. So I think that pharmacies can obviously play a big role in that. I think that's obvious. We've also heard about the clinical benefit of moving towards a system that's much more integrated. And just to address the IT point, I don't think the problem is that people don't believe that pharmacists can handle information correctly. The problem is actually making that sort of integrated system work. So anybody here who thinks or cares a bit about social care will know the difficulties around trying to integrate the social care system with the NHS system more broadly. So I think that it's really an execution problem, rather than, as far as I see it, rather than an overemphasis on the data sharing issues, even though those do need to be worked through. So I think that is really an execution problem. But if I was waving a magic wand, the whole thing would be integrated and much more easily structured, so that you had a clue who on earth you're meant to be dealing with in relation to what issue you had. And the point you made around the web of NHS interactions is completely right. I mean, I know that with my job, having to, when you get constituent query in one area, And I look at a constituent in the audience, Graham Phillips, who has educated me in many areas on community pharmacy over the past few months. And actually, that lack of see-through is a real problem for our NHS, and for what it's worth, I think it's a problem all the way through the NHS, not just in relation to community pharmacy. So I think that clinical benefits are clear. In terms of financial benefits, this is where I think the argument needs to be made much more squarely. I'm, one person, I can help do that, and I'm very willing for people to help me make that case and give me the information and the ammunition to do so. But we all know the pressures on the NHS. We all know that there's a huge amount of untapped, quality, effective resources in our pharmacy sector. And let's use it and show that this can have a positive financial benefit as opposed to a negative one. And the reason why this is important is not just for the obvious reason that you save money, but it's really, really using new technology and integrating that new technology, not so that every single pharmacy becomes, Amazon, we have a sort of central pharmacy, some massive warehouse somewhere, and we do it all by Amazon or drones or whatever. But actually, let's use the technology in a positive way with community pharmacy. I think that that's the trick, because I think that often, if I were to be critical, what it sounds like to people who don't invest the time in trying to figure out anything to do with community pharmacies, they say, oh, all these people just want 10 pharmacies in small towns, that cost a lot of money, they're all together, and why can't you just, where I live, you just get the prescription sent to your house. I mean, that's all you need a pharmacy for. Right, so that perception, I'm not saying that is right, we all know that isn't, but that perception is what needs to be broken down. So I think that the financial aspects to this are also key, and using using this highly skilled set of people and delivery network to affect and positively affect people's health, I think is really important. And then the third thing I want to mention, just addressing the gentleman from Res Publica about the social benefits of pharmacy, is really important. Now, we could spend a long time talking about the impacts of building, why communities are better when they have focal points, and why, if you're elderly in particular, it can be very difficult for you to go a long way for a pharmacy and have that sort of intimate conversation with somebody that you've known and trust over years, in a frankly often a more relaxed way than you might get in your GP, where actually the GP may be actually trying to get, because the GPs are under so much pressure, they're trying to get through appointments every 10 minutes. And actually in a pharmacy, you can go spend time with somebody you know in that social environment that can actually be the sort of, what I like to think of as the great sweet spot between clinical and sort of societal meeting point. So I think that there are huge social benefits for community pharmacy. But I just finish by saying that the delivery improvements that can be made if we can integrate community pharmacy with the NHS, coupled with the financial impacts, make this a no-brainer, whether you're a conservative free marketer, whether you're more on the left of the party or the centre of the party. I think that all of us can recognise that those things are good things, and that's why I'm here, and that's why I support community pharmacy.
But can I just jump in straight away? You said, let's use it. We're 100 yards from the conference main floor over here, and we are not going to hear this. Why is there a hesitation? Why is everybody in this, well, most people in this room assume that there's benefits and efficiency to be had? The message is clear, crystal clear maybe, but there's still hesitation. Why does let's use it? Why the hesitation?
Well, it's a very good question. I asked the same question to Graham Phillips whenever I last saw Graham a month or so ago. I said, if this is also, I get it, so obvious, then why hasn't it moved? All I can say is that at the moment, it is very difficult from a political perspective around all things NHS focused. The NHS is so politically charged, and what the case needs to be made to the right ministers, and to whether it be Sarah Wollaston, who's chair of the Health Select Committee, or various, it's not just the Health Secretary, there are various other people to advocate for this, because I think once the case is made and people understand it, and as I say, look, my mum's a pharmacist, she's always been one ever since I've been born, and yet it took me quite a long time to really understand the benefits of community pharmacy. So, it's not necessarily obvious to everybody, and so I think that making that case to the right people will pay dividends. And we've seen it, for example, and I just give a comparison, with mental health. if you're talking about mental health 10 years ago, it really wasn't a thing people were talking about that much. I mean, maybe I'm missing something, but over the last few years, because of the really aggressive case made by several people around mental health's now a huge focal point for the NHS. These things do get changed by advocacy. They do get changed by people actually understanding why it matters. And if you go into those interactions with that positive mindset that if whatever decision maker it is, or whoever it is, civil servant, senior civil servant, if they actually understand the benefits of this, you can change minds, and I think that you can see that.
Any immediate questions? That's an MP, by the way, telling you that if you make it clear and explain the situation, then the MPs will begin to understand it, which means the problem is yours, not theirs. Any immediate questions?
Wait, hold on. No, hold on. No, that is not what I'm saying. I can't leave that hanging. The point I was making is, look, the best one in the world. MPs have got lots going on. There are lots of different people making really good cases for lots of different areas of public policy all the time. And almost always you're agreeing with people, and so you've really got to understand why something matters. And that's not an excuse for people never to think for themselves. I'm just making the point that if we care about something, you've got to make the case.
Does that mean it has to rise up the agenda?
Yes, that's my point.
Okay.
You've got to make the case to people. You can't expect, MPs to just automatically understand why it's important.
Okay.
Can I say something,
Yes,
James?
James.
So I think that's why it's so important to make a stronger case for the financial benefits that you discussed, Ben. You said that human interaction is the sweet spot between the clinical benefit and the social benefit, but I would say that the human interaction is also the sweet spot precisely for the financial benefit. It's not about technology, it's about the human interaction of pharmacies, because this is the case for a smarter form of triage. This is the case for a smarter form of preventative healthcare. And if we get that right, with people going to the pharmacies in an appropriate way as their first port of call before they put a strain on a GP, which is by definition more expensive, that's exactly the financial case which would make sense to people in government and would hopefully change the political will that we're talking about.
Okay. Any immediate questions? No hands? Oh, this gentleman here. Can you just wait for the microphone? That will come, and then you can tell us who you are.
I don't know if this is appropriate now, but it's a very simple question, bringing us down to earth about wastage.
Okay.
You ready for that?
Any immediate person you wish to address this to?
Well, I think the pharmacist. Ron Wheeler, I'm from Plymouth, I'm a member of the Sutton and Devonport Association. The other day I collected a prescription from my Boots pharmacy and I stepped out of the door, only one step out of the shop, looked at the package and the completely sealed package, and inside were at least two products I didn't need or want or ask for. Stepped back into the shop, I hadn't untouched the packet, it was still sealed, and inside was also still sealed. They wouldn't take the items back. To my mind, that is just profiteering and not, it's just wasteful.
Ian.
Look, there's a whole multitude of reasons why that could have happened. It could have been the pharmacy did order the right medicines, but the receptionists have just reordered everything. That happens an awful lot. The answer is for pharmacy to take control of reordering, because it knows the patients best. It can really interrogate and drill down on a one-to-one to understand what's needed and what isn't. We've got the PMRs to support it. So I think it's an oversimplification, and I get the frustration, and I also get the fact that if somebody goes out the door, why we can't take them back. I do accept that, but then again, we have a responsibility to ensure that medicine's not been tampered, and this is part of the problem as well.
Is there a personal element as well that community pharmacists have a way of addressing inefficiencies built into the system? Now, I've heard statistics that 30 to 50% of medicines are not taken properly. Simply a doctor writing a prescription doesn't necessarily mean there's going to be an immediate cure, and a pharmacist is there to advise and to do something more than just hand something over the counter. And if you lose that one-to-one relationship, what suffers?
Yeah, well, you're opening up all kinds of fronts here, James. We're talking about optimisation, adherence. We're talking about the process of reordering medicines. We're talking about the drugs budget and how we can take ownership of that, control that, and really bring in efficiencies and reduce costs. You know, pharmacies, through incentivised procurement, are saving billions, 10 billion over 9 years has been saved through incentivised procurement. We are the experts in that field. It can be delivered. But these are very complex issues, and they're very complex problems. They're not simple issues you can just fire at the answers to like that.
Any immediate hands?
What that gentleman's just said. Sorry.
Microphone. So tell us who you are.
My name's Karen. I'm from the Fareham Conservatives. I'm also a medical secretary in the private sector.
Can you speak into the microphone? I can't quite hear you.
I'm Karen from the Fareham Conservatives. I'm also a private secretary in the medical sector. Following on from what the gentleman's just said, considering so many countries and charities that don't have medications, can those unused medications not be passed on to charities? Isn't having something better than having nothing?
I agree.
Ian again, sorry.
No,
sorry.
Can the government not do anything
I agree.
to intervene, or
I agree,
pharmacists
but
get
that's the law, but I agree.
There is a scheme.
Okay, is anybody... Hi, can
Just
you...
say that there is a scheme for that.
Yeah, there is a scheme for that. And what does that essentially do?
So
we have presumably medicines that are out of date in this country because we have very specific rules of out-of-date medicine, but actually they're still functioning and can be used.
So, Graham Phillips, I'm a community pharmacist. When we talk about waste, actually, we need to think a bit more broadly. So if I have a chance, I might come back to that.
Okay.
But your point is, well, the reason we can't reuse the medication is simply tampering. There have been examples of people returning medication to pharmacies that have been tampered with. And unless we can, and our test is the friends and family test, would I be happy to give that recycled medicine to one of my friends or one of my family when I can't be absolutely certain about the provenance? And we've seen this with foodstuffs as well, haven't we, if we think about it quite recently. So the reason that we don't recycle the medicine has nothing to do, I promised you, with profiteering, and everything to do with ethics and patient safety. If we want to talk more generally about the efficient use of medicines, then I think we need to look a bit beyond that. What we know is that, as you were saying, James, 50% of medication at least is never taken. We know that when people start their newest prescription, it's probably the most expensive one. And we know that a significant number of people never open the box and take the first one. And that we know that even medicines that appear to be magic bullets with few side effects, like statins, people continue to collect the medicines, but their compliance, their actual concordance, the amount that they take, is 50% or less. So we define effective medicine taking as 80% of doses intended actually taken, and it's extremely rare that people get to that level. The other area of efficiency that we need to talk about is the interaction between lots of medicines and lots of drugs. So if you're, for example, on antihypertensive medication, you're probably on 3 agents to control your medication. If you've got diabetes on top of that, you've got 3 or 4 more, and so it goes on. And we're piling medication on top of medication that not only are people not taking, but there are interactions between the medication and all the illnesses. And the significance of this is that we know that about 12% of hospital admissions are related to the valid and legitimate use of medications. Half of that is because people are not taking the medications, and the other half of that is people are taking this complexity of medications that all reacting with one another, or interacting as we call, does more harm than good. So that's 12% of hospital admissions, but if you go to the care of the elderly wards, it can be as high as 30 and 40%. So we need to think about the efficient and best use of medicines, and this is where pharmacy has a huge potential role to play, far, far beyond the example that we've just discussed.
Just before I go to Celia, Andrew, you want to come in?
Just to quickly chip in on the medicines adherence point, there is really strong evidence that people adhere or comply with the medicines that they're prescribed if they understand what they're for. And the sad reality at the moment is that with very short, 7-minute GP appointments, often the experience is that you walk into a room where you're a little bit intimidated. Within a quick space of time, someone asks you to list your symptoms, writes you something, see you later. And when you don't understand what that is for, then that is what leads to people not adhering, and that's where there is a role for community pharmacy, because if you could go and collect your medicines, and that person has the time to be able to talk you through what they do. You're about to put it in your body, I think it's a reasonable request
Is
it,
there
you want
any-
to know what it does.
Yeah, is there any GPs with it? Or, no. Do you? This is. Do you find it that there's, if we're talking about a kind of mini professional revolution in the way that pharmacists or clinical pharmacists are encouraged to do more, would you as a GP find that either helpful or professionally threatening?
Yeah, I'm Fabio. I'm GP trainee, but also a local counsellor in Ealing. I think it's a really interesting conversation because something, just touching on sort of what's been said, actually in hospitals, I've not long come out of a hospital job, pharmacists are much more embedded in the clinical team and play a much bigger role in, you know, rationalising medications, explaining things to patients. And going into general practice, what you see is very different, that actually the pharmacists are much more separate from the process. And it's always, I've always found that a bit bizarre, really, because actually I think in community they should have an even bigger role. I think the other aspect of it as well is that, you know, we touched on sort of data protection, etc. For example, in hospitals, pharmacists access your blood records, they can access your medical notes, etc. to make so they can play a full part in the team. So, you know, it's the same professional body. So I don't see what those obstacles should be. I worked at GP practice before where they've had an in-house pharmacist, and actually where you have that, or a pharmacist that may come once or twice a week, it relieves quite a lot of the load from GPs. Obviously looking at repeat prescriptions, rationalised medication, potentially having discussions with patients about, you know, patient education topics, for example. So I think, you know, I understand obviously about this going up the political agenda, but I just think also I'm quite surprised how, you know, more lobbying with clinical commissioning groups. You know, there's a lot of decisions being made at a very local level now, you know, with STPs, etc. So, you know, from a council perspective, I sit on the Health and Wellbeing Board in Ealing, and, you know, there's very little discussion actually about pharmacy and the roles that it plays. And, you know, I'm surprised why the commissioners locally aren't looking into this a lot more.
So the answer to the question is you don't feel professionally threatened at all.
Sorry, that was a very long-winded answer.
And you would want them to do more.
I think, yeah, definitely. Yeah. I think they should, and I think.
And you think I mean, this is a Scottish accent you're hearing, which is difficult to disguise. But apparently, lots of what we're discussing here is already happening in Scotland. Anyway, there's a greater degree of integration in Scotland. There's a greater degree of efficiency. There doesn't appear to be any professional differences or envy from either side. It kind of works. It works in Canada. And again, it's coming back to, well, why is it not working here? Why is there a reluctance? Because this is a professional body willing and putting their hands up to say, we want to do more, we can do more, but for God's sake, don't cut our network or you're ruining our opportunity to deliver that extra capacity.
I don't really understand what the obstacles are. I don't really understand why we're even having really this discussion, why the obstacles are in place, because it feels like quite a natural thing that should be happening.
Okay. Any immediate hands? Thank you.
Thank you. I'm Sibby Buckle. I'm the Vice Chair of the English Pharmacy Board on the Royal Pharmaceutical Society. So I've been itching to speak, but I've been trying to stay quiet for the majority of the debate. We had a meeting with Jeremy Hunt 4 years ago, January 2013, where we got the green light for the sharing of the summary care record with community pharmacy. And that was a real red letter day for the profession. But it's actually taken 4 years for that to become a reality. And the problem is, although there might be the political will there, the time just seems to take a long time. So I think you'll find that the community pharmacy profession is willing. We as a professional body are certainly pushing. We're being told that we're pushing against an open door, but we need the support from people like you to use the local examples of where community pharmacies are displaying best practice to convince the ministers and especially the Secretary of State that we need more harmonisation between the GP contract and the pharmacy contract. Because actually, for example, and I'll use this one, it's a little bit controversial, the flu vaccination programme has had GPs and pharmacists at each other's throats because it's an important revenue source for GP practices, it's an important revenue source for the community pharmacy, but also the end goal is to get the right level of penetration in the population so that we achieve, I think we only got 55% last year, penetration of flu vaccinations in the population. Actually, it needs to be higher than that. We need to be achieving 70%. So by the two professions working together, we could actually achieve what we need in terms of patient care and public health. So that prevention agenda is met, as well as the care agenda. I just wanted to, and I'm sorry about this, but I'm going to hold up my NHS card to the gentleman back there. You know, we all operate under a code of ethics in terms of patient confidentiality. So in terms of being concerned about us accessing your records, populating your records, I would get struck off if I did anything inappropriate. And personally, I don't really want to be struck off, and I don't think many of my colleagues do. So, you know, we all operate to high standards. That there might be a bad apple in every profession, but frankly, the majority of us are doing it for the patient and for the good of the patient.
Okay. If there are anybody with questions, I'll come back to you later, but I'm going to introduce Syria. Just a long time ago since I introduced her, but she's the president of the Royal College of Nursing.
Thank you very much. We recognize the need for the government to achieve the efficiencies across the NHS in order to ensure the best use of NHS resources, especially at this time with growing public demand. However, we are clear that the drive towards efficiency savings should not come at the expense of patient safety. Community pharmacies provide an important point of contact for those who may not currently be ill but could benefit from a better understanding of factors that could impact on their future well-being. There is a particular concern about the impact of increased journey times for individuals who live in deprived areas. The 5-year forward view was clear that we need to move from an illness to a well-being system. Yet a key part of the system that is delivering public health support and a minor ailment service is being subject to net cutting funding. It is vital that community pharmacies remain easily accessible where people live, shop, and work. This is particularly critical for individuals in areas of highest deprivation, areas that must not have convenient access to community pharmacy. Community pharmacies support people with specific long-term conditions, including supporting frail older patients with multiple comorbidities. The government needs to provide further assurances that the changes will not damage the pharmacy sector and impact negatively on the services the public receive. We support the aim that suitably qualified and experienced pharmacists play a greater role in supporting health improvement and people with long-term conditions. It must become the norm for community pharmacists to work alongside many more practitioners as a part of a multidisciplinary team. The wider team could include care professionals such as community nurses and, where appropriate, specialist input from hospital pharmacists and social care professionals. This area of care is vital for incentivizing individuals to seek advice on long-term conditions. And I will use a personal experience where I find community pharmacists very valuable. Last year, I tried to get my flu jab. I made several appointments, but I couldn't get to my GP surgery. I was just going to the community pharmacy to collect my daughter's prescription, and he said to me, by the way, have you had your flu jab? And I said, no, I'm trying to get an appointment with my GP. He said, I can give it to you now. So I killed 2 birds with 1 stone where I had my flu jab. Also, another experience I have had with my community pharmacist is that I go to my GP and the prescription is emailed to my pharmacy. By the time I get home, there is a phone call to say, when would you like your medication delivered? They are a vital part of the community. Patients sometimes will go there to discuss drug interaction, side effects, and I am taking this medication, is it all right to take this? GPs are providing a valuable service, but they are time limiting, whereas in the pharmacy, you can have unlimited discussion with your community pharmacy. So we support the need for them to be maintained and not reduced. Thank you.
Any immediate response to that? I can sort of back that up. I spent a day in a pharmacy just as a reporter, standing watching a team. Probably I hadn't watched anybody work that hard for a number of years. What I found interesting was I expected the pharmacist behind the counter to simply get on with dispensing drugs, and found that throughout the course of the day, people would just drift in and out of that pharmacy, asking questions on anything, contraception, drug abuse, almost everything. It was a sort of a strange, not a fairly deprived part of Greater Manchester, but the community pharmacist in that particular area played maybe a role that a formal GP wouldn't have. If a GP is pushed for time, maybe people don't like to ask questions, maybe they don't want to waste time. And I think the government are missing a trick there. We were trying to figure out what this actually meant, and I suppose what it means is there is an NHS presence in the high street that is underused. It's a resource that's just waiting to be used. I don't quite understand the reluctance, but there is some, and we've heard a bit of that this afternoon. So any immediate questions on that idea of a underused resource? Before one lady at the back.
Yeah, Jill Clark, I'm a party member. I mean, with respect to disease prevention, it's worth remembering that politicians get far, far more votes by waiting for the population to get diseases such as cancer and then throwing money at that rather than preventing people getting cancer in the first place. And if you want a greater role to play in disease prevention, then the starting point is simply to educate the population, the voter, quite honestly. I mean, I was quite interested to hear how politicised the NHS is. It's purely a political organisation.
Where have you been for the last 50 years? The NHS is politicised. I mean, that's...
I'm not part of it. I mean, you know, I'm well aware of that, but you've got to understand what the ramifications of that are. And as I explained, politicians get far more votes from waiting for people to get cancer and then throwing money at the situation rather than preventing people getting cancer in the first place. I mean, that's the only reason I can account for why Professor Richard Doll proved the link between lung cancer and cigarettes back in the 1950s. And in 2007, I went into the Royal Marsden Hospital, and what did I see? A smoking room. And nobody thought there was anything strange about that at all. But there's a huge education process to be put in place if you want to start preventing disease.
We're down to the last speaker. I don't want to say we've kept the best till the last, because that's going to be just too difficult. But Ian Strachan is the chair of the National Pharmacy Association, and I hope he'll present, maybe round up what some of the speakers have said already, but maybe offer more numbers than we've heard so far,
I'll do
which
that,
is a
like.
difficult task, and it's never easy to do in this surroundings. But Ian.
All right, well, thanks, Ian. Well, first of all, I'm going to say I love drones. I mean, I'm always flying drones. I absolutely love them. I'm always flying them. I've got my favourites. But I know what a drone won't do. A drone won't help an immobile, vulnerable person live independently in their own homes for longer. A drone won't take a message back to the pharmacist to give reassurance, support and advice to somebody living on their own. If you took a pharmacist and that support that network gives through those delivery drivers, what that's effectively doing is reducing the demand on social care on a scale that you can't even begin to comprehend. Nearly every pharmacy in the country has got a full-time driver that's not paid for that. That comes out of the pharmacy budget. Your drones won't do that. Your drone won't take 24 bottles of Fortisip and 3 boxes of Movicol or whatever on a delivery, on a mission. What pharmacists do and their teams is they help people stay living independently in their own homes for longer. Now, you've got to put a price on that. This is what this government is playing with right now, and this is what part of the message that we've got to get over. Now, I've been to the Labour conference. My team have been to all the conferences, and you know, there's a resounding theme coming across those conferences, and that's been this willingness, if you like, to see community pharmacy as a solution rather than a cost burden. And we've approached delegates. We've won the delegates' choice of stand. And the kind of feedback that we've had off delegates in making those votes was pharmacy is relevant to our daily lives. Where else in the health service can you walk off the street and get advice from a highly trained professional in minutes? That was one comment. and your pharmacist, you see the same person and their team, and that's really helpful. People like that consistency they find in a pharmacy. And this one I really like. You are the NHS on the high street. Now, I'm going to hold on to that one. We've chosen blood pressure at this as a theme because it's a good example of all the things that your high street pharmacy, your chemist, can do to improve public health and relieve pressure on the NHS. Now, according to NHS England, we spend 7 billion a year treating cardiovascular disease. High systolic pressure is the top cause of death from cardiovascular disease, but it's more than blood pressure. We're given a detailed assessment of a patient's health, heart health. We're already trailing this service in Essex and Gloucester, and at the other conferences we detected arrhythmias. We detected, I think, about a dozen. We referred patients to hospital. Now just imagine if that pharmacist could have intervened, put that patient on losartan, stabilised the arrhythmias, and took out the whole system cost that goes with a GP referring to a cardiologist, the cardiologist making a diagnosis, that being referred back to the GP, and the time that was involved, and the way we could have mitigated against risks and potential complications from that being undiagnosed. If you truly want to liberate the potential of these people, that's where you start. Now, we're going to stay with some numbers now, and I want you to hold with these numbers. I want you to stay with these numbers as best you can, because these numbers are all evidenced, and the registered numbers I'm going to talk about have all come from NHS Digital 2015 to 16 on their QOF data tables. The expected prevalence data I'm going to talk about is from Public Health England's disease and risk factor prevalence models, and the HRG, that's a word for Healthcare Resource Group, that's the cost for having a patient hospitalised. That data is from the 2015-16 tariffs for those conditions, okay? So this is all evidenced. Now, there's a staggering 8 million registered hypertensives who have been diagnosed. 1.3 million of them are not on target. There's a further 6 million that are undiagnosed. There's nearly 12,000 pharmacies. If every pharmacy in the country just did one blood pressure screening a day, that'd be 5 a week. That equates to 3 million screenings a year. Now, if you work on the basis that 25% of those screenings will result in a diagnosis, then you've got 750,000 new cases per annum. Those lifestyle interventions from a pharmacy would support primary interventions, and we estimate that empowering community pharmacy in this way will, on their own figures, so I've just used these figures, and these are government figures I'm talking to you now about, reduce stroke admissions by 30 to 40%. The average length of stay with a stroke is 10 days. The healthcare resource group cost is between 7 and 10,000. We would reduce myocardial infarction admissions by 20 to 25%. So the average length of stay there is 5 days. The healthcare resource group costs are 3,500 per patient. The reduction in heart failure admissions, by at least 50%. And the average length of stay in a hospital for heart failure is 10 days. Those could be eliminated, and this is the reason why pharmacy is to all of this. It's because we have the access and the capacity to do more, and that's why this stuff's frustrating. Because we're there, we're accessible, we're convenient, the public love us, and I think they do, and we've looked into that. You know, it doesn't make any sense. So we're part of this system that stands out as having the capacity and the skills to improve the quality-driven outcomes that we all strive for. And I'm sorry, people challenge me on this, but a surgery managing a complicated caseload, and the doctor might help me out here, might see a complicated regime, a patient 4 to 5 times a year. A pharmacist sees that patient 30 to 35 times a year. And it's those interventions, those points of contact on lifestyle choices that pharmacy can influence, which makes the difference. It's that behavioural content. A pharmacist in a surgery might be able to work on formula reviews and on some of the costs, but they will not reduce bottlenecks, and they'll not challenge they can't address the challenges facing a cash-depleted NHS. The primary care system wasn't designed for that. I think the average appointment with a doctor is 10 minutes. So we're not about trying to replace doctors or threaten doctors, because we're not the challenge to doctors, but we do believe we can support them, and we do believe we can be part of that answer. This is also an evidence figure, that around 650,000 A&E appointments a year and 18 million GP consultations could be managed through community pharmacy. And we're crying out to just give him the chance. I'm going to end in a minute, but by just saying that, and something I want you to understand here, and there is a term, it's a cliche, and it is a cliche, and it's called a clinical pharmacist. And it's used to differentiate the high street community pharmacist from this more clinical professional. And I tell you, all pharmacists are clinical pharmacists. Put that one to bed. Do you know that 80% of pharmacists working in doctors' surgeries are from a community pharmacy background? You know, you might say, does it really matter? This is a bit esoteric. This is just you talking within the... It's not esoteric. It's a deliberate attempt to be divisive. It's a deliberate attempt to block the ability of community pharmacists to play a central role in NHS policy. And that's the sad thing about it. And that is why this is so damn difficult. Because it is a prejudice. And it's really getting to a point now where we're going to flush this out. What they're doing is gating out community pharmacy and that high street network as a solution. And it's backfiring now because the evidence all points towards integrating community pharmacy network to address system pressures. And the evidence is there that we can do it. And I'll just give you one example of that. This is a study by, I think James mentioned it earlier. This is the Alberta model. This is a Canadian model. What they did across the 12, 13 provinces of Canada is that they liberated the potential of pharmacists by getting them engaged in a self-declaration of competence to prescribe. So it made a quicker access to be able to deliver. And one study they did was on systolic blood pressure. That was done by a full-scope intervention by community pharmacists, education, prescribing, consultations, and it was reducing systolic by 18 millimetres of mercury, above what could be achieved through the classical surgery setting because you haven't got the same contacts. You know, this stuff's not rocket science. And if anyone wants this, I'll email it to them. It's not a problem. I'll close with this thought. We need to think more radically about using this unique open door approach which exists in a community pharmacy. We had an appointment to 1.6 million people a day and give us the opportunity to integrate health and social care across the entire pathway in the communities that we serve. I tried to speak in that debate at 9 o'clock this morning on STPs and get my hand up and I just couldn't get in there. Anyway, my colleague did. Graham Phillips always seems to get in there for some reason. But if we align community pharmacy, it can be a core solution in primary care that will help us all meet the capacity gaps that exist right now. And I'm absolutely convinced about that. And I'm, as a pharmacist, I've got pharmacies in Bury, Liverpool, Saddleworth, and up in Blackburn. And, you know, that's what I am, first and foremost. And this is the frustration because we could really help you out.
Okay. If anybody was in doubt that you go to fringes and political conferences and you don't hear passion, that knocks it back. I actually think that, you know, maybe Ian was talking about, I mean, lots of his vocabulary there was quite antagonistic. I actually have been watching this debate as a political journalist for a year or so now, and I genuinely think, as Bim said, actually the gulf between the two sides is getting smaller. I think the arguments are being made in a fairly heated manner, but they are being listened to. It's not necessarily an us and them anymore. It's a group, part of the NHS, who are saying we can do more. And I think we're looking at 3 or 4 years of difficult government, and I think eventually there's large parts of the government are looking at community pharmacy as potential allies and friends rather than as distant enemies. Any immediate questions just to close? Yes.
Yeah, thank you very much. I'm Michael Jackman. I'm a Oxford Western Abingdon member, and I would just like to say that I agree fully with what's all been said, but how are we going to tell the government this is the thing? I mean, do our best. I mean, I've got rheumatoid arthritis. Most of my medication comes via my GP. I've got one Humira, which I have to take, which is from the, comes via the Nuffield Hospital in Oxford. And so, of course, the doctor is not involved with that, but still has to monitor it for me. So this integration is a real big thing. It has to be made better, and it's just how we can tell the government that this is what we need.
Thank you very much. So, at the back there.
I just wanted to make a comment. My name's Lucy.
Oh, sorry.
My name's Lucy Murray. I'm based in Battersea Association. I'm an NHS dietitian, and I just want to make the comment that definitely acknowledge my perception is that community pharmacists are massively underutilised. But also, just to sort of open up the discussion, as we're talking about relieving the pressure, also talking about the role that maybe dietitians might have in terms of patients with type 2 diabetes, helping to reduce long-term complications, providing tailored dietary advice, undernutrition and COPD, massive potential to reduce admissions, saving the NHS money, and not only dietitians but other allied health professionals as well, physiotherapists, OTs.
Anybody else? I mean, yeah, are we getting back to the idea that the original founding principle of the NHS was really primary healthcare? Where the complexity and the money is down at the very complicated end. Are we talking here about primary care, about actually assisting at the very beginning of health process rather than the end?
Yeah.
Anybody want to pick that one up?
No?
Yes.
Well, I've been listening to.
Can we know who you are, please?
Oh, I'm Pam Tracy, actually.
Okay.
Do you want to know anything else about me?
You don't have to give a full CV, just...
No, okay. I'm from Gloucester, actually. Yeah, and I've got all the symptoms what that gentleman said. As well, I'm a rheumatoid arthritis patient. I've got something wrong with my leg at the moment, that's why I got it on here. And first of all, I've got to say, I have great pleasure in my pharmacy, which has moved into a centre. I don't think that's working, to be honest, is it? No.
It is working.
And the Asbin Centre in Gloucester. We started off with a pharmacy. I remember all the little pharmacies, blah, blah, blah. Listening and with all what has been said here today, it all falls back, staffing, aftercare, etc., with what you were saying earlier on. Okay, we got a busy pharmacy, chemist, as one would say. We go in there and I want off the street attention. First of all, how do I get, does the pharmacy drop everything and come to see me? Or do I have to make an appointment? And then another second question, does that involve extra staffing?
Okay.
And that's probably the third, would it have to be a pharmacy or would you bring somebody especially trained for that?
Let's go back to James's original point on what,
but this
what more can be done.
MP can take that back.
And you can I'll let James come and then I'll come back to Ben.
There's loads I could go on with, actually.
So yeah.
Thank you for not doing that.
The gentleman who asked the question, how do we make this case to government? How do you speak to government? So you've got an MP here today who has told you very clearly what you need to do. You need to make the financial case for community pharmacies at a time when public finances are at the forefront of government thinking. There's no more cash in the kitty. And you say, Sibby, that you're pushing an open door. You've been told that you're pushing an open door. You're not. You're pushing a very closed door. The clinical case has been made. Department of Health get it. The social case has been made by organisations like ours. And government gets it. You can speak to fantastic local MPs like BIM who can talk to the Treasury and say this is the benefit of community pharmacy, but there's not the money there to enable you to do what you want to do. So if you want to make that case to government, you've got to answer this question about the financial viability, the sustainable economic model that you represent at a time of, unfortunately, a time of imposed austerity. Now, I would suggest, as I said earlier, that could be answered in two ways. And this is where I really want us to focus on the human as opposed to the technological when it comes to community pharmacy. What is the unique added value of human interaction that you get in a community pharmacy. So when I mentioned triage, we talk about in the newspapers recently that GP receptionists are going to be the first port of call, where you have to pass through a secretary before you can see a GP, and if you can't see a GP, you take yourself to accident and emergency, and the costs of that just get bigger and bigger and bigger. If a community pharmacy can be the first port of call when it comes to triage and to deciding who has a chronic ailment, who needs to see a GP, who can be dealt with within a pharmacy setting, that is a cost efficiency which can be made to the Treasury. Secondly, what is the added value of the human networks, the existing embedded networks within communities that pharmacies have at their fingertips? Now, you can't replicate those. You can't conjure them up through a kind of Amazon model, and GPs don't always have access to them. So there's all this talk about what pharmacies need to do to be brought to the table with GPs. I would flip that around and say, what can GPs learn from pharmacies when it comes to these embedded community networks? And the last point when it comes to financial savings, as I said in my talk earlier, are what are the social savings that we can argue for in addition to the clinical savings? So if you look at BMI and the links to something like unemployment, which has been proven in peer-reviewed journals by medical authorities, how can we cost that and map that and explain to the Treasury that by enabling community pharmacy to play a stronger role in preventative primary health care, there's an added benefit, an added saving to the public purse that comes from those social effects too?
Can I bring in Boom quick?
Yeah.
Well, I agree with a lot of that. I'd like to take on what the lady said about was the dietitian, and she was talking about effectively primary care in a more holistic sense. So you much more eloquently described what I was trying to get at when I originally talked, which was if there can be, and again, part of this will be making a case to government, but part of it will require ministers to strategically set out their vision for what they think primary care should look like over the next 5, 10, 15 years. Because if you take a broader view, and I know we've obviously spoke a lot about pharmacy, but if we just take a broader view and use other sorts of health professionals at primary care, added to the financial pressures, added to an aging population, added to the increased cost of drugs, and everything to do with healthcare in terms of cost is going up and up and up. And I'm not now even dealing with the demographic problem around the public finances because you've got an aging population. I mean, all of these things lead towards more primary care, not less, and more integrated primary care, not less. And so, in addition to the point around making a sustainable financial case for an economic model that works, I would go further and say how that fits into a primary care health system that's fit for the 21st century. Because again, when you're dealing with somebody in the Treasury or Department of Health and they're looking at the whole system, they might even appreciate the financial case that's made in relation to pharmacy, but they may find it difficult to understand how that fits in with other aspects of primary care. And so again, it's about thinking about it holistically that's really important. We too often think about the NHS as hospitals and GPs, and the NHS is a lot of, or even more precisely as doctors, nurses and GPs. You know, that's what the NHS is, doctors, nurses and GPs. And the NHS is a lot of other things too. And so that is the sort of debate that I think is already happening, but again, it just needs that further articulation, I think.
Any immediate suggestions? And then I'm going to round up actually about 15 minutes earlier. There's some wine and stuff outside, but let's just...
I won't keep you from the wine, okay? Thank you. My name's Steve Churton. I'm the past president of the Pharmaceutical Society. I'd just like to make 3 observations, really. First of all, you saw the passion with which Ian spoke. I would have to say to you that every single pharmacist I've met is as passionate as Ian. Maybe not as confident or as articulate as Ian, but they're passionate about patient care. They're truly passionate about doing the best for their patients. And I'm afraid to say that some of the decisions which we've seen taken recently is in danger of sucking out that passion from pharmacists and from compromising their goodwill. That's a real shame, and we just do need to recognise that and do something about it.
One other point.
2 more points. The second point is the point was made about, well, what's the barriers here? Patients don't really understand what pharmacists are capable of. if that's true, and it is true, then it's not surprising, is it, that politicians also don't know what pharmacy is capable of. Politicians are patients as well, yeah? The third point, and now I'm speaking just as a vice chair of a clinical commissioning group for a moment, yeah? There is an opportunity here. Commissioners don't recognise the value of pharmacy. They do in our CCG, only because I happen to be there, because pharmacists don't have a right to sit on CCG boards. They are clinically led organisations, and by that I mean GP-led organisations. So there's a huge opportunity with STPs as they transition into ACSs for pharmacy to be at the table.
I'm just going to round up by saying, James mentioned that pharmacy, if you like, is knocking against a closed door. Yeah. My concern is over the next 4 years, it's not going to be a closed door, it's going to be a door nailed shut with the hardest and tightest lock possible, and the money is going to be tight. And that if this is the level of passion at the moment, then if the government is going to be convinced that change is necessary, the passion is going to be has to be turned up even higher. The arguments are going to have to get more focused. And if you like, a campaign has to do more than just make a couple of noises against the government. There's going to be a lot far. But I think what we've heard in the room over the last hour and a quarter or so is a degree of consensus, which I haven't heard at other conferences completely, but is entirely encouraging. And can I just, as a journalist, can I thank this panel for the contributions that they've made, and to the audience. And to the audience themselves, who, without decent questions, without decent knowledge, none of this ever works. And that was actually good fun. I enjoyed that. Thank you. Brilliant.